We're going to continue our morning, and this is a panel discussion, and we will be discussing understanding data limitations and promise of health informatics. My name is Lynn Grief. I wear several hats. I'm on the planning committee. I'm immediate past chairperson for the Board of Certification for Emergency Nursing. I'm on the research committee for American Board of Nursing Specialties, and I'm vice president of trauma at Blake Medical Center in Florida. So welcome. Our first speaker today, we have two, Ronda Hughes and Murielle Beene will be speaking the background paper of the significance of data harmonization for credentialing research. Ronda is an associate professor at Marquette University teaching applied statistics, health policy, and clinical quality improvement. Murielle Beene is chief nursing informatics officer at Veterans Health Administration at the U.S. Department of Veteran Affairs. They're both members of the IOM Standing Committee on Credentialing Research in Nursing.
Thank you, Lynn, and thank you for all of those participating in today's workshop. One of the things that Murielle and I had been spending a lot of time discussing over the past couple of months is that when it comes to the issue of data and information, people discuss it as a problem, they describe the pains that they have, but then basically the discussion then turns. And so what we found is one of our greatest challenges is basically how do you describe error? So we went about trying to do that in hopefully a sufficient way. One of the things that we found with data and information is the issue of variables. Where do you start? Where do you begin? So a lot of people talk about that they're data rich. The challenge is, as a researcher, as a clinician, is actually how do you bring that together in a meaningful way. So it's not necessarily just an issue of a dichotomous variable. Does somebody have a credential? Do they not have a credential? What does that actually mean? Are these variables, in fact, mediating, moderating, modifying, are these intervening variables something that can actually be used to address research questions? And again, do it in such a way that those findings can be acted upon, that those findings are generalizable. One of the greatest challenges with data and information is accessing it, and accessing data that's adequately standardized. So for example, a lot of folks talk about information and data that they have, but when you actually try to link those databases together, what you find is that you are dealing with mixed fruit, mixed vegetables, and legumes, and trying to make something that is actually meaningful. So it's no longer the issue of a fruit salad. It's something that has so many flavors and colors and dimensions and properties. Again, how do you do that in a meaningful way? And link that to outcomes. Not necessarily just outcomes for the patients, which by all means is probably one of the most important things we can do in healthcare research, but also looking at organizational outcomes and individual outcomes. That being said, one of the challenges with data is standardized data. So one of the things you find is, as we were looking through the different databases that are available now, is that each organization has come up with their own database to meet the purposes of their organization and for credentialing, but for purposes of research to really understand the meaning of credentialing. Those databases don't necessarily lend themselves to accomplishing such a task. We also found that the content of these databases varies significantly. So in other words, the data itself can be something that's collected on an annual basis, something that's collected maybe every 5 years, or something that's collected on a more readily updated basis. The other challenge is even within healthcare organizations themselves. Going into their databases, do they have updated information that really reflects the credentialing of the clinicians and within the organization? And what we found in almost every instance is that these data were out of date and not necessarily reflecting what was currently going on in the organizations. The issue is also looking at observational data, and how do you link that with a granularity so that you can really see what is the impact of a credential. So one of the challenges is, how do you measure someone who has a credential versus someone who's highly competent, or in other terms, a turbo clinician? That type of clinician that many of us aspire to be, or that we ourselves want if we're receiving healthcare, or we seek out care within an organization that is credentialed or not credentialed. How do we really differentiate that? How do we really know that this is beyond the basic training, the basic standards, and then again, it is something that is not necessarily just credential. So if you're comparing somebody with a credential versus somebody who is highly competent. Again, another term that's very controversial, a lot of different definitions. How do you do that in a meaningful way? We started off with claims data, and the majority of the data that we use in healthcare research looks at claims data, which is retrospective data. There is no way to find out who basically influenced the care of that patient without extensive consternation. One of the things that we found too is that as we have evolved with the implementation of electronic health records, while that may actually let us go back and look at what's going on during the processes of care, there are so many hands that interact with that patient during a care visit or during a length of stay that it's almost next to impossible to say that this positive outcome was related to this credentialed individual, or that this positive outcome was because they were in an organization that was credentialed versus not. Again, so we can talk about data and we can say we have data, but when push comes to shove and you actually have to use it from a research perspective to do quality research, or even from an administrative perspective, the data and information are currently not available to do that. There's also the issue of valid and reliable data. How do you do that in a meaningful way, again, across organizations, across these different databases, when you have to understand that the majority of this database is not accessible? It really reflects intellectual property of organizations, whether they are the credentialing organizations or healthcare providers themselves. So even if money is not an issue in purchasing this data, the actual ability of gaining intellectual capital from others to address key research questions that we're going to be discussing as part of this workshop are very challenging. So when it comes down to data rich, data poor, one does need to start with a question. And then when you start with that question, where is the data? And often researchers have found that the data is not available. And we're optimistic that in the years to come, a lot of this data will become more available so that we can actually accomplish a lot of this research that we're going to be discussing. That being said, when you get the data, what do you actually do with it? And that's one of our greater challenges.
So it's really important to think about, when you think about data and how it needs to be organized to actually be meaningful. Hopefully that the discipline of informatics can help us get there. And one thing that informatics as a science does is that intersection between information science and health science and computer science will help us process and organize that data in a way that puts us in some type of a common data information model. And these data information models will be very helpful to try to bring these pieces together. And so why do we care that we want to put data together in a way that's organizing? Well, it will help answer some of these questions that we're here today to answer for credentialing research or whatever research we're trying to investigate. So one process that really helps, where informatics can really help us in this space, I really believe, is in the space of interoperability. And why do we care about interoperability? Well, interoperability takes that common data information model and turns it into something that helps in an environment where different data information can be exchanged. Data can be exchanged. So for example, if you have an information system, as Rhonda discussed, that has this proprietary information, if we care about the way that the data is organized, it will help these systems come together. This is the process to help us get us there. And what's problematic in our current space is that really relatively our clinical information system, our information systems altogether are really at level 2, where we do a lot of our processes are inside of our current systems. They're really respective to our organizations. Where we need to be is level 3 or level 4. Where we need to be is really, if you want to answer those questions about, you know, individual versus organizational, what credential, what characteristics really made that difference, I believe that, or we believe that, if you get to level 3 or level 4 of interoperability, it will help us get there. So some of the barriers to actually getting to these environments that will help us answer these questions is really cost and funding. I mean, there's a lack of funding. It's really expensive to have these technical environments or technology environments that really help us get these data in a way that when the researchers get to the data, that they're able to use it to inform the questions that we're trying to answer.
Along with that is the issue of accessibility and availability. For years, we have found in the research community that when we actually do get access to the data, it is not what it has been promised to be. The other challenge with that as well is to do it in again, a meaningful way and looking at the integrity of that data. So for example, some things are based on a fiscal year, some things are based on a calendar year. Trying to bring harmonization to that has caused premature aging in many researchers.
And with the data harmonization, you want the data to be accurately exchanged in the same context. Just like Rhonda spoke about the legume salad and the apples and the fruit and all the vegetables, when we look at these data, we want them to be together in a way that when we look at them and we're doing our analysis, that they make sense. Currently in our state, our electronic health records are not interoperable. They're not. They're really proprietary to the system or the organizations they're intended to serve. We're making steps to get there, but we're just not there yet. And that's one of the largest barriers of us getting these different data in a way that we can, like, again, use it for research and answer these questions.
So one of the challenges in moving forward is really the need for a common data model. Definitions are something that's been ingrained in me for a long time, and that's one of the issues is that we need consistent definitions and not definitions that are necessarily proprietary to a certain organization or meaningful to a certain organization, but definitions that are meaningful across organizations, across systems of care, across databases. So when we do that, it also will facilitate bringing this data together so that we can harmonize it and so that the data can be interoperable. It's also basically putting forward a minimum standard or a minimum basis from which we can then build robust data systems that will really help us get to these questions that we are trying to achieve.
Interoperability really can't work it needs to have a technical environment that it can work in. And there's several that have been proposed in the literature, but one in particular has been the service-oriented architecture. And in that architecture in general, interoperability and the exchanging of data meaningfully and in that proper context can be achieved. It definitely is something that needs to be explored. And another technological advance that we could look at is probably cloud computing to some degree, and see how that can help inform this as well.
Great, and thank you.
Thank you. What we plan to do is to have each of our speakers give their presentation, and then we'll take answer or questions at the end. Our next speaker is Patricia Dykes, and Patty is going to be speaking on harmonization and performance measure development to evaluate credentialing. Patty is a senior nurse scientist and program director for research in the Center for Patient Safety Research and Practice and the Center for Nursing Excellence at Brigham and Women's Hospital. She's also assistant professor at Harvard Medical School, where she has a program of informatics and patient safety research. Welcome.
Good morning, everyone.